So first we have Dr. Carol Paris. She is a retired psychiatrist who worked for more than 25 years in community mental health, prison psychiatry, and academia, including a year as a consultant psychiatrist in New Zealand, where she experienced a single-payer system firsthand. In 2003, she entered private practice, becoming a small business owner. This experience, more than any other, opened her eyes to the failings of the US healthcare system. She became an outspoken critic and has been advocating for a single-payer Medicare for All program ever since. She served as president for Physicians for a National Health Program from 2017 to 2019 and continues to serve on their board. Dr. Paris has appeared on national television and radio programs, given numerous presentations, and in November 2019, debated the merits of Medicare for All with Mr. Chip Kahn, CEO of the Federation of American Hospitals at the School of Health Policy at Vanderbilt University. Dr. Paris received her medical degree from West Virginia University School of Medicine, where she completed her residency training as well in adult psychiatry. We also have Dr. Ed Weisbart. He is a family physician in St. Louis, Missouri, and chairs the Missouri chapters of PNHP, a nonprofit, nonpartisan research and education organization in support of providing an improved form of Medicare to all Americans. After practicing family medicine for 20 years at Rush Medical Center in Chicago, he moved to St. Louis in 2003 to serve as Chief Medical Officer of Express Scripts until retiring in 2010. He is currently an assistant professor of clinical medicine at Washington University in St. Louis, Missouri, volunteers in a variety of safety net clinics and other nonprofits across the St. Louis area, and serves as president of Consumers Council of Missouri. He received his medical degree at the University of Illinois in Chicago in 1979 and completed his family medicine residency and a fellowship in family medicine education at Michigan State University in 1982. Dr. Weisbart is a national speaker with several articles published in both national medical journals and local media regarding the healthcare needs of the uninsured. We also have Dr. Monica Maalouf. She is a primary care internist and an assistant professor of medicine at Loyola Stritch School of Medicine. She did her undergraduate training at the University of Chicago, where she studied biology and anthropology. She went to medical school at the University of Minnesota and completed her residency training at New York University School of Medicine in New York City. Her medical interests include HIV care and women's health, with a particular focus on marginalized communities. She is the co-president for Northern Illinois of Physicians for a National Health Plan in Illinois, and is an active member of the Illinois Single Payer Coalition. And last but not least, we have Dr. Richard Bruno, who is a double-boarded physician in family and preventative medicine at a federally qualified health center in Baltimore, Maryland. He has been active in local, state, and national organizations, serving on the board of directors of the American Academy of Family Physicians, the National Physicians Alliance, the American Association of Public Health Physicians, MedChi, the Maryland Academy of Family Physicians, Sugar Free Kids Maryland, Friends of Hampden School number 55, Hampton Family Center, Roland Park Civic League, Wyman Park Community Association, and Physicians for a National Health Program. He has been advocating for Medicare for All since his first year of medical school, organizing rallies and workshops for health justice and helping co-fund Students for a National Health Program. He attained a bachelor's degree from Princeton University, Doctorate of Medicine from Oregon Health and Science University, and a Master of Public Health from the Johns Hopkins Bloomberg School of Public Health. He graduated from the Combined Family and Preventative Medicine Residency Program at Johns Hopkins and MedStar Health. So, as you all can see, we have a really, really great lineup of people today. And so without further ado, we're going to start with Dr. Weisbart.
I gotta tell you how excited I am to be here. It was kind of fun hearing the backgrounds of the folks that I work with so often. So that was pretty interesting. The run of show, as I understand it, is I'm going to spend a few minutes sort of unpacking what single payer Medicare for All is, sort of the nuts and bolts a little bit, with an emphasis on why y'all should care about this, why so many physicians do care about this. And then I'll hand it off to Dr. Paris, who will make it a little bit more real in terms of the physician-patient relationships and other great insights she has. She'll then pass it off to Dr. Maalouf, who will, I believe, mainly discuss the impact on the horrible disparities in healthcare that we have. And then to bring it home tonight, before we do the dialogue, will be Dr. Bruno, who will sort of explain a bit more about how he got SNaHP started and why students should be involved and what students can actually do. So it looks like a fun little section here. Let me get some slides going. If you know me, you know that I'm a slide junkie. So I believe you can see my slides now, correct? So like I say, we'll talk about what it is and why y'all should care about it. We'll start with a simple cartoon of what it is. There's all of us on the left, and then there's all the things we want out of healthcare sort of on the right. And of course, between us all is the money. And the money today is managed by payers. So the U.S. government is a payer, right? They pay for the healthcare for the military, for most of Medicare, and a variety of other things. Then states, this is a Missouri-centric slide, so that's Missouri. They pay for Medicaid largely and other things. And cities, we pay for our school teachers and such, and schools, and businesses, and insurance companies. So we have an incredible collection of payers in healthcare. So we have what's called a multi-payer system. And if you think about that, that means that in one way or another, we're each paying each of these payers, and then the payers each have their own contracts with each of the people or organizations that provide healthcare. A big, complicated system, and this is a cartoon simplifying the complexity of this system. So what we're proposing instead is to get rid of all that and replace all of that with just one payer instead of this complex mess. And we think the most efficient way to do that would be to build on the track record of success of Medicare and improve Medicare and provide that to everybody. A little less cartoony version of that, what that means is, as I said, improving Medicare. So Medicare, the improved version that we're talking about, includes all medically necessary care, including prescription drugs, including mental health at parity with every other kind of healthcare, dentistry, hearing, long-term care, abortion care, full reproductive care. So all medically necessary care, and it would be delivered free at the point of service. So under the program we're proposing, there would be no copays, there would be no deductibles. And if you have no copays and no deductibles, then that means you don't have to buy any other crazy little healthcare insurance product like we have today. People who have Medicare today have to shop for supplements and Medigaps and Advantage and stuff that we could spend hours talking more about. The need for that disappears under this because you've already got robust access to healthcare with nothing to pay at the point of service. So it greatly simplifies things, and the funding, instead of through essentially regressive premiums like we have today, the funding would be equitable through a progressive tax structure. So that's sort of the core of what we mean by improving Medicare, although there are other features. And then leave nobody out, nobody left out. So include every resident in the United States, regardless of whether you're working or not working, whether a pandemic made you lose your job, regardless of your immigration status, everybody, cradle to grave, basically, being included in it. And you'd have it, therefore, for your entire life. You wouldn't have to worry about changes in your life circumstances, meaning a change in whether or not you can get health care. It would mean, sort of to unpack it, obviously, it would mean that you wouldn't have to worry about whether you had a pre-existing condition. If you have diabetes or cancer, no insurance company could deny you because everybody in the country would have this coverage. It would mean not every doctor would participate. There would be, I think the number is 7% of physicians today don't participate in Medicare. The number would probably be smaller under Medicare for All, but there would be some physicians who would not participate, but pretty much the overwhelming majority of physicians would be available for patients to pick from amongst, not have to ask for permission from, and pretty much virtually every hospital. So patients would be in control of these decisions. If you're spending 3 months, in some other part of the country for some reason, you're still in network. Your network is the entire United States and even some travel coverage. So you wouldn't have to worry about the kinds of things we worry about today. So can we afford it? I'm not going to do a deep dive, but just to tell you, there have been dozens of studies from different economists all around the country for years that have said, of course, there would be new costs, but there would be new savings. And they've almost all said that the new savings would be at least as much as the new costs. And most of the studies say the savings would be larger than the new costs. So most of the studies say we would save money. In fact, I think last year it was that hundreds of sort of the top tier of economists have said that we have to do this now. And now is the time for it. And most strikingly, the Congressional Budget Office, nonpartisan group, came out for the first time in decades and analyzed the single payer proposals and said, yes, we can expand benefits in the way you're talking about. And yes, we can eliminate copays and deductibles. And yes, we can achieve universal coverage for the entire country. And yes, it would be affordable. So even the Congressional Budget Office now is saying this. So I would say the science about whether we can afford to do this, that's a resolved question. There's politics, of course, but the science, the economic science is done. So why do you care? Why should physicians care? And I would actually say Friedrich Nietzsche said it best, of all the people to quote in a healthcare talk. But, you know, you go in to see a patient and you figure out a plan, and then you find out that they can't get it done because they can't pay for it, or their insurance company says no. And so you come up with plan B or plan C or nothing, and then you go on to the next patient. And you have this pattern repeat itself over and over and over again. And I'm here to tell you, the stress, the anxiety, the aggravation, the indignity of being told that your professional decisions, where you know your patients can have their lives transformed and saved, the fact that we're so often robbed of the ability to help our patients, that accumulates. And that's the main thing we have to fix for ourselves as well as for our patients. And it's, you know, there's data to show that indeed we are an unhappy lot. So welcome to medicine, folks. You know, we are actually the second, we're almost the least happy doctors in the modern world. The good news is the German doctors are less happy than we are. I don't know why that is, but, you know, cultural differences. But we are measurably unhappy. And I would say that the main thing driving it is because of the non-clinical bureaucratic nonsense that pulls us away from doing what we love to do, which is, you know, frankly, seeing patients. Can show you all sorts of data about how we are distracted from that, but I think this is the single most compelling thing. So electronic medical records, sort of a non-negotiable data point. Somebody, you know, Epic is one of the most common electronic medical records in the world, actually. And when Epic goes live in a hospital or in a clinic, what they do is they send people around. They're called Epic Mavens, and they send them around all over the hospital or clinic to customize the electronic health record to meet the exact needs of that setting. So Epic at Washington University, where I volunteer at, is different from Epic at a hospital in Chicago or in Tennessee. It's different in every place, and it's actually different all around the world. It's the same software, but it's customized everywhere. So somebody extracted from Epic the number of clicks you make in a progress note when you do an ambulatory care note. And it turns out that around the world, in Canada, UK, Australia, you can see the countries there, the average progress note for an ambulatory patient is about 1,000 characters in many countries around the world, until you come here. And in the United States, the average progress note is 4,000 characters, 4 times as long. So when you're in your clinical years, in your practice, and you're getting the sense that 3/4 of what you're doing when you're charting has nothing to do with patient care, that's because 3/4 of what you're doing when you're charting has nothing to do with patient care. It's got to do with medical risk issues. Why would somebody sue you if they knew the future cost of healthcare was covered? Medical legal risk really goes down under this program, and it's got to do with optimizing reimbursement for the maximal progress note. You don't need to do that under this program. So it wouldn't overnight mean better progress notes, but it would set in place a system where this problem, as just one metric of why we're so unhappy, would improve. Turns out that salaries for physicians around the world and in many countries are actually nothing to sneeze at. So here's clinical payments per physician in Canada in Canadian dollars, and Canadian dollars are about 25% less than here. But remember, they have much lower office overhead. They have, and these numbers by themselves are are pretty decent. So why should you care about this? The first is that profoundly decreased administrative burdens, as I showed you a little taste of. Second is I believe that that would contribute to making us much happier in our careers and not compromising our earning potential. So with that, I'm going to turn it over to my buddy, Dr. Carol Paris.
Thanks, Ed. When I was practicing as a psychiatrist, I often said that the only person whose mental health I cared more about than my patients was my own. And I think that, I think we all know the physician heal thyself. We need to take care of ourselves in order to take care of our patients. And as medical students, I think it's important for you to ask the question, why am I learning all the things I'm learning? I mean, I know the Krebs cycle is important, at least to get through first year of medical school into the second year. But in 4 years, you're going to be finished with all this book learning, and you're going to be taking care of patients. And you're going to have to come to terms with dealing, as Ed pointed out in his first slide, the morass of insurance companies that we all have to deal with. So I'm just going to tell you one quick story about an experience I had towards the end of my career. I was working in Maryland, and Richard will know, Dr. Bruno knows, Care First Blue Cross Blue Shield is one of the big corporate run insurance companies in Maryland. And I had my office staff came to me, my billing clerk came to me and said, you have about $2,000 worth of outstanding, accounts receivable. And these are people who had Medicare as their first insurance, and then Care First Blue Cross Blue Shield is their second. So I said, well, let's look into this. Maybe something went wrong. And we determined that Medicare, hey, they paid their share of it the way they were supposed to, and they actually electronically sent the bill on to Care First. And then we found out that Care First coded in the wrong physician identifier number and sent $2,000 of my money to a doctor in Fredericksburg, Virginia. So here's the long and the short of it. As an experiment, and I don't recommend that anyone else try this experiment, you can just tell my story. But as an experiment, I had my staff pretend that they were lawyers billing every 15 minutes, keeping track of every 15-minute increment of time that they spent until I collected that $2,000. And the long and short of it is that 1 year later, when I calculated what I pay my staff and what it cost us in mailing, certified mail, and refaxing and re-Xeroxing and re-everything, it cost me $3,000 to collect $2,000. So of course, I would not recommend anyone do this, but I did it because I wanted to be able to use this example of the phenomenal amount of hassle that they put doctors through simply to collect money that we have worked for. And they do this because they hope that in most cases we'll throw our hands up and say it's not worth collecting, and then they make more money. So that's a little story to exemplify what happens to doctors day after day after day after day that takes its toll on us. And I think that the toll that when I first heard the term burnout, that rankled me. I thought, am I burned out? because all the things that they recommend for burnout were things like, well, you need to take a vacation, or you need to meditate, or you need to do some yoga. And all of that implied that there was something wrong with me, and I just needed to do something else better, and then I wouldn't be burned out. Well, then I discovered a term that resonated far more honestly to me, and that's called moral injury. And moral injury says when when I experience a negative feeling and stress, it's actually a normal response to an abnormal situation. And what needs to change is not me. What needs to change is the system. And so really that kind of tells you in a nutshell what got me involved in PNHP. I decided I'd had enough experience working with MedChi, the state medical society in Maryland that Richard is a member of still, trying to get the insurance companies to play fair. And finally I said, you know what, they're always going to find a workaround. They're always going to find a way to thwart anything we do. If I'm going to beat my head against a brick wall, I might as well make it a really big one. Let's make it a federal one. And let's go for the gusto. And that's when I joined Physicians for a National Health Program. So I'm going to finish out by saying that really, I was starting to experience moral injury around 2006. I didn't stop practicing until 2014. And what it really got to reached a pretty critical point in 2009, and that's when I joined PNHP. And what got me through the last years of my career was actually the work I did with PNHP, activism, being an outspoken critic and of our healthcare system and advocating for a national health program. So if I can finish there, I'm going to see if I can share one quick picture. I don't know if I can. Let's see. Let's see, screen share. Here we go. Can you see that?
Yes, we can.
All right, that's a picture of me protesting at a Trump rally in Nashville in 2017, when Donald Trump had come there to try to strong arm our two senators, Alexander and Corker, to get them behind his first iteration of a piece of legislation to try to put an end to the Affordable Care Act. And what I was saying, what I was chanting was, put your name on a plan that works, Medicare for all. I ultimately, I wasn't arrested that time, but let's see, I'm gonna stop screen share. I wasn't arrested that time. I was thrown out of the meeting, but I'm happy to say that two things. Number one, I got Donald Trump to stop talking for about 30 seconds, maybe not quite that long. And I used Donald Trump because he was not even the focus of my action. That action was actually designed to get my member of the House, Jim Cooper, to co-sponsor HR, it was then HR 676. And 3 weeks after that action, he became a co-sponsor. And I really think it's because he figured, this woman is just crazy enough to do something like this. She's never going to leave me alone. And so I'm saying that with humor because I want you to understand this was a joyful experience. Activism is a joyful experience, and it is an antidote to the kind of moral injury that I hope I hope we can put an end to so that you guys can have happy careers where you don't have to worry about moral injury. So I'm going to finish there and turn it over to Dr. Maalouf.
Thanks, Carol. That was such a great, wonderful story. I love I love Ed talking about physician burnout, and then you saying that activism is an answer to that, because I do believe that myself as well. Moral injury, not burnout. So I, much like our, Dr. Weisbart, Dr. Paris, I think what got me involved in the single payer movement was my clinical experiences. I think since I was a medical student, I had a few, I trained in Minneapolis, and I worked at both really rural clinics and our county health system in Minneapolis. And then when I trained in New York City, I got to work at a federal, veterans hospital, as well as Bellevue Hospital, which is a county hospital, and got to see the sort of the breadth of our healthcare system and the inequities embedded in it. And I think what stood out to me so much throughout my, early years of practice was just how much finance worked itself into the exam room. How often I was thinking about money, thinking about how patients were going to pay for their meds, pay for their treatment, who I was going to send them to, and how they could afford it. And it just always was it was just such an unnecessary and demoralizing part of practice. And I also realized that so many of those conversations happened with my Black and Brown patients. So it led me to ask a lot of deep questions and get really involved in the single payer movement. And so, so here I am today. I think that I'm going to spend a few minutes just talking about kind of my exploration of some of those topics and how it relates to single payer. And in doing so, and talking about the inequities in our healthcare system, I think I'll take you guys on a 5-minute history trip, because I think it's important to kind of reflect on where we've been as a country and how we got to where we are, especially today as we're talking so much nationally about health inequities, health disparities, racism in medicine. So I think that it was really surprising to me as a young physician that, and maybe naively so, that, this is not the first time as a country we've had this conversation about Medicare for all, right? Bernie Sanders and the progressives in Congress are like pushing it forward and giving it a lot of momentum, but we've been having this conversation for like 100 years. And back in the early 1900s, when racism was embedded in the US healthcare system, because the US was post-slavery, hospitals were largely segregated. And in the 1930s was the first time like health insurance started becoming a thing, and it was tied to people's jobs, like Blue Cross Blue Shield became a thing. Those types of privileges were denied to Black patients, to Black Americans. And over the next decade, people started to realize, oh, hey, there's an inequity. Like some people in the US are getting healthcare. I mean, their conversation wasn't about Black Americans, but about white Americans, some getting healthcare, some not, and the cost of healthcare. And President Truman at the time was the first one to propose this idea of a national health plan. And so we had this conversation already, like I said, almost 80, 100 years ago. And the opposition came from a lot of different groups. One of them was the AMA, the American Medical Association, was staunchly opposed. And they talked a lot about how universal healthcare was socialist or communist. And it's so funny, we hear those same words today. And the South was opposed because this idea that we're just going to let, everybody, including Black people, into our hospitals, like this is crazy. Why would we do that? And so that idea kind of died, and the rise of our current insurance system, the way it is, it like ran rampant. It wasn't until the 60s when we passed Medicare that hospitals were forced to desegregate. So in the 1960s, we passed the Civil Rights Act, and then shortly after, Medicare passed, and they were both federal programs. So in order to get Medicare money, and most seniors in the United States at that time were, being covered by Medicare, hospitals had to desegregate. And so that's kind of what challenged our healthcare system to advance to allowing or pushing doctors to take care of Black patients. And those roots, this sort of like racial tensions, these inequities, these are so embedded in the system, and they're still there today, right? So when we talk about healthcare and who can access it, and we still see that so much of that at play today. We see health disparities across the board. There's been so many studies. I'm sure you guys as medical students have had some of these conversations, but we see disparities in care and outcomes. Black women still have the highest peripartum mortality rates. Black men have some of the highest mortality rates from colon cancer. Black and Hispanic Americans are more likely than white Americans to be uninsured or underinsured. And we've also seen studies that have shown that when you give people universal access to healthcare in systems similar to like the VA, the veteran system, or with Medicare, when people get old enough to qualify for Medicare and they get insurance, Black Americans, Hispanic Americans start to have better outcomes. They start to live longer. They start to live healthier lives. So a lot of the disparities and equities that are built in, like we start seeing them, and there's so many, interesting studies that have shown this, but we start to see them get eliminated when we give people universal access. So I think for me, it's a really important moral question today. Like if we truly want to challenge our healthcare system to be more equitable, to provide care that is really not disparate, we have to talk about access. People always worry that Medicare for all will cause like rationing of care. This is like a common question that comes up whenever we do like a community forum or a town hall, like, hey, if we give everybody healthcare, like how am I going to get into a doctor? I'm going to have to wait, like what's going to happen? I tell people we already ration care. It's just along racial and socioeconomic lines. If you're a Black patient or you're a Hispanic patient, you're uninsured, you already have to wait. You already can't access care. And for some reason, we're able to swallow that. But when we talk about kind of making the system more equitable, eliminating that specific hierarchy, people get worried that we're going to take away, their healthcare. So I think for me, this is like a big like moral and ethical challenge and calling for physicians in the 21st century. Like if we want to make our system, if we want to talk about racism in medicine and access to care, we have to talk about the racial disparities that are embedded in it, and that we can help to start to dismantle them by embracing a universal coverage system. It's not the end all be all, but I think it's a big part of that puzzle. I guess I'll end it there. That's my short version of a talk that I've given before that takes up a full hour, but happy to answer questions and talk more about this further. I'll pass it on to Richard Bruno.
Thanks so much, Monica. That was very, very important background to where we are right now. And I think you really can't talk about universal healthcare or Medicare for all without talking about how it addresses some of these racial disparities and these inequities in our system, because it totally flips the game there. So thanks for that. I would love to hear your full hour talk sometime too. So maybe I can catch that at some point. And thanks to Carol and Ed before me. I think really want to continue on the sort of like burnout and activism as a burnout prevention thread, because I think this is a very important narrative too. And I know that it's a hot topic right now, especially among medical schools, residencies. It's like, well, let's give them more yoga classes and let's make it easier for them to like go and like go do trips, go take some money and go do some trips together. And that really sort of like is almost victim blaming, right? It's like, well, if you're burning out, it's because you are not equipped. So here's some things and you can take that and go get equipped with some. And I think it really speaks to the fact that they're not addressing those system level problems that really are fueling the burnout, which has really gotten worse during the pandemic. Medical economics survey from last summer showed 71% of physicians are burned out, right? So it's like, it's caused not just a sort of uncovering of the festering wound, but sort of ripping the Band-Aid off of the festering wound and really showing us that like these systems are unsustainable. I kind of got into the movement my first year of medical school. I was out in Oregon. During my first year, one of my high school friends died of a brain tumor that probably would not have killed him or bankrupted his family if he had just had health insurance at the time. He was in a rock band. He were touring all over the country. He got too sick to do that and ended up working at a pizza spot. And when he got too sick to do that, ended up cutting hair in his house just to try and get money. People were throwing, shows, rock shows to try and raise money for Luke's chemo. Like it was really one of those moments where it seemed so unfair for somebody who didn't deserve, didn't want or ask for this kind of this disease, was unfairly punished and untimely, killed by that. So that sort of set me into this motion. It's like, why am I trying to become a doctor in a system that like perpetuates these kinds of injustices? And I started doing some reading, and I found Andrew Wilper's paper from 2009, which calculated that 44,000 uninsured Americans were dying every year simply by being uninsured. And this was a paper written by some PNHP founders. I was like, PNHP, that sounds cool. I went to the conference in Boston, my first year of med school, and met a bunch of students and residents and young physicians who were really fired up about this. And we ended up sort of creating a PNHP chapter at my medical school. I teamed up with one of my faculty members, Paul Gorman, who helped us get things started. And we ended up throwing rallies in the middle of Portland, Oregon. We put together, we nailed 550 crosses at the along this promenade along the river to signify the 550 Oregonians who were dying every year, uninsured Oregonians, simply by being uninsured. Really trying to highlight in sort of like very visual ways these injustices that were continuing to be perpetuated by this unjust system. We held a conference. We invited Margaret Flowers, who I had heard speak at PNHP, who is Carol's buddy, and we invited John Conyers, who was the former congressman who basically wrote the initial Medicare for all, single payer bill that now Pramila Jayapal is continued and improved upon. And we just brought people together, got them together, and had discussions, dialogues, actions to really show and highlight how important it was for young physicians to get involved in sort of trying to change them and improve this movement. And then one of the cool things is, we would have these meetings, and we would say, like, who else can we invite? Let's get some big names. Let's bring some people to town. Let's build this up. And one cool event that we had was with Wendell Potter. He's a former Cigna vice president who had an epiphany when he drove through, help me out, I think it was in Tennessee, right? It was West Virginia.
Wise, Virginia, just over the border from Tennessee, where his family is from.
Right, so he was driving to Tennessee. He passed a remote area medical event. RAM is like it's like they go to really, really disparate places that have very low penetration of providers, and they put on these full day or 2-day events where they just have people coming out and they can just get healthcare from providers. I volunteered at one since. Pretty amazing organization. I wish they were more single payer minded, but they're not. But Wendell Potter had seen one of these. He'd seen people getting care in like the animal stalls at the county fair grounds where they had been putting on this event. And he's like, what am I doing with my life? All I'm doing is perpetuating and denying people care. So, the company makes money. So he had a complete change of heart, wrote a book called Deadly Spin, where he talked about the industry sort of, their tactics and strategies to deny care to people. And he was going on a nationwide book tour. So we snagged him, we brought Wendell Potter, and he spoke to our whole med school. And it was those kind of things. I think we were just really trying to galvanize folks and really help kind of convert them from sympathizers to activists. Because once you kind of look through the data in any sort of health policy class that you may take on the subject, it's pretty obvious, as Ed presented a lot of the data that compares US versus other countries, that we're far behind. So that was really kind of a fun way to sort of get that going. And then with some other chapters around the country, we sort of were meeting at the PNHP conferences every year, and we were like, let's just create our own version of this that's not just med students. Maybe we can bring in nursing students and dental students and public health students and any other pre-meds or anybody who wants to sort of put some energy behind the movement. And today, SNaHP has 95 chapters across the country. So it's really turned into an amazing organization. supported by PNHP, but making its own decisions, holding its own conferences, bringing in its own speakers. And if you guys have an opportunity to get to go to any SNaHP conferences or be a part of some of the larger efforts nationwide, I hope that you get a chance to do that. I was going to tell you a story about getting arrested too, but I do want to leave some time for some questions and maybe some dialogue, and love to hear how you guys are, what you're doing with your chapter at Tennessee, and if you have questions about things that you are hoping to achieve with your chapter. And thank you so much for having us today.
Thank you all so much. That was really incredible to listen to. Also got me really excited about like what you said, Dr. Bruno, I think is something that will stick with me personally, is changing from sympathizer to activist. It's a huge step, but I think pulling more people in to have that mentality is what's really going to move this movement forward. But I would like to go ahead and yes, open the floor to any questions about anything that was said or anything in general about Medicare for All and SNaHP.
Okay, I have a lot of questions, but my first one for Dr. Weisbart, you were mentioning about how there are like 7% of physicians that do not take Medicare right currently, and that it would be less, but there might still be some if we have this Medicare for All system. So can you talk about what that means? Like how can would a physician not be able to take this Medicare for All if it's, essentially what every person had in America?
Sure, and that's why it would be a very small group of physicians. So there's nothing in the proposed law or in PNHP's recommendation that says, doctor, you have to take this as a form of payment. There's nothing that says that. And like I said, today, there's 7% of physicians today who say, hey, I don't like this Medicare stuff. I'm just going to charge retail and come and see me if you want. So there are some who do that today. There would be fewer. There would still be some who would do that tomorrow, but they would be fewer because under Medicare or with Medicare for All, they would be telling literally everyone, not just the younger people or older people, literally everyone who lives in their community that I know you're paying for insurance. You're not uninsured. You're not choosing to be uninsured. You're not in any of those circumstances. I know you're already paying for your health care through this federally equitably funded program. Despite that, if you want to see me, you got to pay me full retail at this price. So there would be some who would choose to do that, but today they're targeting a relatively small niche, and tomorrow the niche of patients who would be able or willing or want to do that would be far smaller than it even is today. So some could do it. If you want to do that, you could do that, but hardly anybody. I mean, it would be a really small number. Is that what you're asking me?
Yes, that makes sense. I guess I was just kind of wondering, like, who would they see at that point? But
they would see the wealthy. They wouldn't be seeing the uninsured because, there wouldn't be any.
Right.
They would be seeing people who have enough money to pay for their health care through the equitable tax model, and on top of that, want to spend more. So, there would be some. But the point is, you don't want to, you could never make a solution that solves every problem, that captures every piece of the pie. You can't do that. If you try to do that, you won't get anything. And the good news is, you don't have to do that. You don't have to do that. You don't have to compel doctors, force them. They're going to all want to, for the most part. And so you don't have to push for a, every doctor in solution. It'll do that on its own.
Okay, thank you.
I also have like 10 billion questions, but I'll try to narrow it down to a couple. Dr. Paris, I know in your bio, it was mentioned that you worked in New Zealand for a year. Could you maybe speak to like what differences you saw in New Zealand and how that affected like the physician-patient relationship on a day-to-day basis?
Sure, I'd be glad to. In New Zealand, everyone is covered by their national health program who is a resident of the country. So that's for just medical care. They also have something called the Accident Compensation Corporation, which as a visitor to the country, I paid a nominal amount into. But what it means is that anyone in the country, even if you're not a resident, if you have an accident while you're in New Zealand, all of your care is covered. So if you decide to go visit New Zealand and you trip and fall and break your leg as you're coming down the stairs from the airport or from the airplane, all of your care is paid for. So what does this mean for patients? Well, when I would talk to patients and they'd say, well, you're from America. I said, yes. And they said, well, didn't Obama, you have national health care now, don't you? And I said, oh, no. They didn't understand that what we did in 2009 and 10 didn't give us what they have. And they simply, it was really hard for them to wrap their heads around the idea that they would actually be expected to pay money at the point of service for care. And they just expected that it was paid for as part of their insurance. I mean, their taxation. From the provider standpoint, it meant that I spent a year never having to fill out an insurance form. And the only form I had to fill out was, they have a very liberal drug formulary. But if I wanted to prescribe a medication to a patient that was not on the first tier of the formulary, I simply had to go in and explain why I wanted to do that. And then it was automatically approved. So that was the sum total for a year of my having to be hassled. Oh, and when I wanted to hospitalize a patient, I just did that. Nobody said, well, you can't do that, or, you know, if you haven't ever tried to get a patient in the hospital, it can be maddening sometimes as a psychiatrist, having people question your clinical decision making. It just didn't happen there. Now, was the system perfect? No. But I'm hard pressed to give you an example of something that was really awful. Yeah, maybe some of the hospitals were not as modern as all of ours. They still provided perfectly wonderful care, but they were still in the process of modernizing some of their hospitals.
We have 2 questions in the chat. So I'll start with the first one. Maybe Dr. Bruno, you would be a really great person to start with, is what can students do on our end to push for Medicare for all?
Hey, yeah, absolutely. Thanks for the question, Mario. And I'm happy to field these. I would say number one is, like, first of all, you know, as your group figure out what you want to do, what kind of actions you can take. Sometimes that takes sort of like, you know, coordinating with other chapters or talking with our national coordinator and talking with other students around the country about what things that they're doing. But supporting the 2 bills, I think, are good ways. Representative Jayapal from Seattle and Senator Sanders from Vermont both have Medicare for all bills. They're slightly different. You can look at some of the nuances there, but you know, finding ways that you can advocate for pieces of legislation. You know, as PNHP and SNaHP, we have to sort of remain impartial, being 501c3s, so we can't necessarily endorse certain candidates. But legislation and policy, you know, are the things that we can you know, bring research to finding ways of advocating. And I think it's really, at this stage, I think it's really, really important, because it looks like some of you guys are first years, maybe some of you are upperclassmen. Keep those patient stories really close to your heart. every time that you see a patient that is struggling in this healthcare system, you're going to be the one sitting there next to their bedside for half an hour, hearing their story and keeping those stories close to you, and retelling those stories to the people in power who have the ability to change the system. You know, being an ally for your patient is one of your greatest assets at this stage. So remember those stories, write them down, keep them close to your heart, retell them over and over and over and over, so that you can be that advocate and that ally. And then I think for the second question about RAM, yeah, I know this was a disappointing thing for me. I actually went and volunteered in Maryland at a RAM event about a year ago, and I wore my single payer button on my white coat, and I was asked by their people, some of their the folks there, to take it off because they thought it was too political, and I pushed back a little bit and said, this is not political, this is policy, but I put that beside me. I went and I saw a lot of patients and took care of a lot of people who really, really needed help. And I did a lot of good that day. But when I had a chance to take a photo op with the CEO of the company who was there, I kind of asked him, like, I hope that we get single payer someday so that, I know RAM wouldn't be necessary at that point. And he kind of said, yeah, well, we're not really kind of pushing for that. And I'm not sure exactly sort of like the thoughts behind it. I wish that they would be more sort of like supportive of universal healthcare, because it would solve a lot of the problem that they're trying to fix, being sort of like a band-aid on a broken system. But I don't know. It turned me off a little bit, but I still think they serve a very important role. I work at a safety net clinic right now, Federally Qualified Health Center. Until we get universal healthcare, these are necessary. I won't say evil. They're very necessary steps to keep people alive. So I think it's really important that we continue to keep our eye on the prize and really fight for what we know will be the best thing.
Can I jump in with two little quick things? I've volunteered at a lot of those sorts of clinics through other organizations too, and it seems like a lot of the people there who volunteer at them are coming from an idea that charity can solve the problem, and so they have that sense. And to me, that says we have a remaining large reservoir of opportunity of people who do actually care about taking care of people, but who haven't yet figured this all out, because there's overwhelming evidence that you can't possibly ramp up a charity care system adequately to solve this. But if I could, one other quick little thing. Carol mentioned that hospitals in New Zealand are yet to be modernized. Here's how we love our hospitals. Here's a bunch of modern hospitals, and these are how they look in Canada. These aren't American. Hospitals are very nice in many countries that have single payer stuff. So just wanted to point that out.
And can I add one thing to the first question about what can medical students do? I would just like all of you to know that it was the action of medical students at the AMA convention 2 years ago in Chicago that resulted in the AMA leaving a horrible dark money organization called the Partnership for America's Healthcare Future. And it was as a result of a protest, a die-in, and just massive shaming by medical students at the AMA that resulted in that happening. So you have more power than you realize.
Yeah, absolutely. And any of us on the call tonight, I'm sure would be happy to be in touch. Andrea, hopefully you can, if you're willing to, let our emails be available. Happy to continue this discussion, and obviously happy to connect you with other folks from other chapters and at the national level, so we can get some good ideas going and have your chapter be successful.
Yeah, I talk to a lot of my students about kind of picking your level of advocacy. Like, you can do things institutionally, like at your own hospital like this, like organizing talking events. You do things regionally, like in your community, at the state level. looking at state legislation and then at the national level, either through national policy or influencing national organizations. So that push on the AMA was like major, because AMA, as I kind of briefly mentioned, was always a staunch opposition to universal healthcare, which they still kind of are, but at least they made this like soft statement that they're like not gonna, they made sort of a soft borderline statement a few years ago after a lot of med student pressure. And I really think like you guys are the future. The generation of physicians right now, I think the recent studies showed that like, I think 55 to 60% of physicians support Medicare for all, but I think those numbers are much higher in our upcoming students. And I think that like vocalizing that, mobilizing that into action is really going to change perspectives, because I still get a lot of questions about like, oh, like, aren't doctors opposed to this because you're not going to make as much money, or like, doctors don't like this. This isn't what doctors want. And to some extent, they're not wrong. There is a large population of physicians who are not in support of Medicare for all, but I see that changing with this upcoming generation that is you all. So, so keep that, spirit alive, and yeah.
Thank you, guys. One question that I have personally is, I've realized through this pandemic and also this conversation that we're having now, sometimes numbers and statistics and those things don't mean a lot to people. They get really blurred on the internet, and you can give them all this information, but they still don't really listen. And I'm learning that things like patient stories and personal stories mean a lot more. So when you're having a conversation with someone who's maybe on the border or doesn't know something about Medicare for all, or is maybe opposed, how do you start that conversation? How do you structure it? Because I know it can get really involved and you don't want to overwhelm them, but I'm just kind of curious how you sort of start that.
That's like such a profound realization that you've had, because I've said this a few times. I said this quote a few times, that a single anecdote I think is more powerful than an entire volume of scientific evidence. When it comes to winning debates, or not, I don't want to call them debates, but like conversations, like people will carry stories with them. They're not going to carry data and facts with them. And I think, as you said, during the pandemic, we've seen that, right? Like you can present volumes of scientific research, but like one anecdote may overwhelm all of the evidence that suggests, for better or for worse. I think I always start my conversations off by listening to what people have to say. I think people's concerns are very valid. I think people are afraid about their health, their relationship with their doctors, their ability to get treatment and care, and their family's ability. I don't think that a lot of opposition to this is like selfish and malicious. So I like to listen and like hear where they're coming from, and then use that to help shape how I answer that question. And I do that a lot with narrative storytelling, but it's also helpful to kind of know a little bit of the evidence and science behind it, so that you can help bolster and support the arguments and claims that you're making. But I think, like Dr. Bruno said, the power of patient stories is so influential. And so when you guys are meeting patients and rotating and at different clinical sites, and like hearing those stories, and being able to translate those into a story that has a message to it, is something so powerful. So thinking about ways that you can do that as well. But I think the first step is really just hearing what people have to say and what they're worried about. And then you'll come up with ways to answer those concerns that are very evidence-based.
I agree with Dr. Maalouf, and a way that I think of it is, we all have the same needs and values. Those are universal. It's our strategies for meeting those needs that is where we disagree. But if you can join someone first by acknowledging, wow, it sounds like freedom is really important to you, and that's really important to me too, and then expanding on that as the way of opening keeping the conversation going. I have never successfully won an argument with statistics and data. I have beaten people to death with them. I have bored them to tears with them. I have never won an argument with it. I have used them as a tremendously important support, but standalone, it's never been effective for me.
Thank you. Thank you both. I know we started late, so I'm sorry, but does anybody else have any more questions?
I just one last question I had was, I guess this is for everyone on the panel. Are there any specific resources or books that you guys would recommend for medical students to?
There are, as I'm sure you know, a lot of books now. That's a good one. Tim Faust also, and Jerry Friedman has a good one. But I actually think this is the book I've been waiting for 10 years. This is the book that has the information, the stories, and does it in a way that's not inflammatory, but kind of really plows through and gets you. And this is the best book I've seen. I've got a whole stack of them on my shelf, but I really recommend this new one by Abdul Al-Sayed and Micah Johnson.
And Micah Johnson is a early career physician, I believe, isn't he, Ed? He's not even a mid-career.
There's this picture.
This is the benefit of Zoom conferencing, is you get show and tell that you don't get in real life conferences and speeches.
That's right. I'm not going to bring my whole bookcase with me.
That's what I did. I just went to the bookshelf. Books that were really influential on me when I was a medical student was Fitzhugh Mullins' White Coat Clenched Fist, that documents when he went down to Mississippi as a medical student, and sort of the activism that he did in his residency at Jacobi. A really important book of being an activist as a student. This is the book I mentioned earlier, Wendell Potter's Deadly Spin. Really, really important sort of treatise on the way that our healthcare system is engineered for the worst. Anything by John Guyman, he's a PNHP doc. He writes a series of books, and he's up in Seattle. Hijacked is a good one because it kind of talks about, it kind of lays out, this is a few years old, but how we can kind of get the single payer in the midst of Obamacare. Tommy Douglas was the famous premier of Saskatchewan who was a Baptist preacher who had a congregation of people who were not getting health care, and helped basically start the first single payer system in Saskatchewan that then went nationwide, and now is revered as one of the greatest Canadians of all time, but because of the work he did to implement their single payer system in Canada. Really, really cool guy. And then something more modern. I don't know if you guys know Abdul El-Sayed. He ran for governor of Michigan. He was former health commissioner of Detroit. He's a big single payer guy. He's a CNN commentator now, and he's really helping bring the single payer, Medicare for all type of language, and continuing to push on this. He was also a Bernie surrogate during the last election. But his new book, Healing Politics, talks a lot about that as well. Really important book.
Thank you so much for the recommendations. I have a long list to start reading now.
Another like just helpful non-book research. There's a podcast that's done in collaboration with PNHP called Medicare for All Explained. They're like 20-30 minute episodes. I did one recently. I think, Ed, didn't you do one recently?
I think I did the first one. Actually.
Yeah, and then Dr.
Susan was a friend of mine.
And then Dr. Susan Rogers, who's the current president, she did one recently as well. They're like nice 30-minute, you can listen to it when you're driving, and really informational. So that's something else you guys can check out.
Well, thank you all so much. If anyone has any more burning questions or didn't get to them, please send them my way. I will send them to our panel. We will get you answers. I did send a list in the message of all the resources that were named, and I can send out that list too. And also for our UT students here, the exciting thing is that I got a long list of links of Dr. Weisbart's talks that he has done, and we will be sending those out to the entire student body. So those will be some also short snippets of information for learning about Medicare for All and how we can get involved. I really want to thank this panel so much. You guys have educated us a lot. I hope, and I'm sure I don't speak for myself, that you've also really motivated me to open up these conversations with people, classmates, future coworkers. Obviously, if we're here, we think this is really important, but thank you all so much.